going to talk about sepsis and septic shock. The reason why we're talking about this tonight is because cycle 6 starts because of the COVID crisis. They've decided to terminate cycle 5. Cycle 6 is going to be coming up June 1st. And unless anybody's taken a national registry before June 1st, you'll be running into sepsis questions. Subsequently, we're going to have a nice lecture on it today. I'm going to cover everything that's been covered on the questions written so far for the National Registry. If you know this slideshow, you're going to know all the questions for the National Registry, and you're going to obviously know how to treat septic shock. So here we go. Anybody have any questions before we start? Okay, so first things first, can everybody see the screen?
No.
All right. How about now?
No, it just looks blank.
Oh, okay, I'm still working on it here. Still nothing?
No.
All right. I apologize for this, folks. This is not something that I've had a problem with before. It's always been interesting to try and get it started, but by now I've usually had it figured out. So first of all, this thing's.
I got it now.
Yeah, I can see your
PowerPoint
slides.
presentation. Yeah.
Okay, you guys got it. All right, great. All right, well then let's get started. Sepsis and septic shock. I'll be your host this evening, Jim Frame. I'm your medical director for PERCOM, lead medical director. And what we're going to talk about today is sepsis and septic shock. Now, again, cycle 6 is starting. Subsequently, you're going to see questions now in the National Registry for sepsis and septic shock. And I have been slowly but surely changing my graduate interviews with each of the PERCOM students to include a sepsis scenario. So once again, everything that you're going to see and hear on this particular slideshow, it will be represented on the National Registry in some form or another. Know the slideshow, you're going to know the 4 questions that are going to concern themselves with the sepsis portion of the National Registry. Now, these questions are going to be mostly about the criteria and elements that you use to diagnose sepsis or septic shock, and then we'll get into the treatment. The beauty of it, there's a lot of explanation for the presentation, pathophysiology, and the mortalities, but the treatment is relatively straightforward. So fortunately, this isn't going to be hard to treat if you recognize it early enough. And we'll get into some statistics here in a few seconds. So, slideshow, and we will start. Here we go. All right, so it's the 3rd leading cause of death now in the United States. Can you believe it? I do. We see a lot of it in the emergency department. As a matter of fact, I would say that 1 out of every 6 patients that come into the emergency department now from especially nursing homes are coming in extremis. Most of that is because the nursing home personnel are either not skilled or trained in recognizing early sepsis. I'm sure they recognize that their patients are at risk for anything that will cause death. When you think of nursing homes, you think about more people not making it out of a nursing home to return to any kind of normal life. So obviously we're at end of life care. This is the definition that you're seeing here right now is a life-threatening inflammatory response to infection that injures tissues and organs. We're going to get more into it in a few seconds. Now, sepsis is triggered by a systemic infection, and there's going to be various sources for infection, but here's the key. You don't need a readily identifiable source of the infection. You may think of pneumonia, urinary tract infection, soft tissue skin, abscesses, cellulitis, intra-abdominal problems for patients that have diverticulitis or gallbladder disease and such. All of a sudden they develop an infection in their abdomen. You don't really get to see these folks until they have some sort of other complaints, such as abdominal pain, nausea, vomiting, intractable diarrhea, bloody diarrhea, maybe vomiting, blood, bilious looking type vomit, or even dark or black looking type of vomiting as a result of a small bowel obstruction. Now, we all know, and everybody knows from the coronavirus, influenza virus and such, that coronaviruses have resulted in the deaths of 34,000 patients here in the United States. Influenza usually takes anywhere from 25 to 50,000 patients a year. The difference between the coronavirus and the influenza virus here is that influenza, we've got a test for it, and we've got a vaccination for it, and we got a treatment for it. Coronavirus has none of those three. We don't have a vaccine, we don't have a good treatment as of yet, and we don't have a readily available test for it. So subsequently, we can't identify who's at risk except by signs and symptoms. Well, by that time, it's just a tad too late. They're running a fever, they're having shortness of breath, difficulty breathing, they may have some pain in their chest and such. Well, I just named, your last 8 out of 10 calls to any nursing home. So again, it's hard to identify those folks, and that's what's resulted in so many deaths. Now, we're going to talk about field management and such. We're going to talk about the ways that you can identify sepsis and septic shock in the field. So here's your National Registry tips. And you guys know that I write questions for the National Registry, among other people that sit on the committee. But from the last conversations and such, we have generalized topics that we want to introduce to you. We know that with patients that have sepsis and have now become hypotensive, and we define hypotension as a blood pressure less than 90. When fluid resuscitation antibiotics are delayed, if you pick it up early, 16% mortality. 1 out of 6 to 1 out of 7 people still pass away. If you have a person who has a normal blood pressure, but they've already have altered mental status, then you can get somewhere around a 30% mortality. In other words, 1 out of 3. And of course, late identification with all of the above, it has a mortality of greater than 80%. So can we call it a preventable death? And the answer is no. Once you start into the sepsis cascade and such, it's really not preventable at that point. And of course, we all know from human history that there's no way to avoid infections. All of us have had them, all of us have had fevers and we feel miserable. We've had virus infection, bacterial infections, and who else, what other kind of infections that are out there. So it's not really preventable, but there are strategies that we can maintain that can improve a person's chance for survival. Now, 2 things that you're going to see in the literature, and something that we're bringing up at the National Registry level, is that Center for Medicare and Medicaid Services, National Institute of Health, and some of the other major institutions that are out there have recognized that Levophed now is the first line of pressor support, vasopressor support for sepsis. Just like Levophed is the first medication that we use for cardiogenic shock, in other words, big O anterior wall MI, which carries an 80% mortality just by itself, but the patients have already become hypotensive. 60, 70 systolic pressures. We start a bit of Levofed on them, 1 to 4 mics to begin, and we can push it all the way up to 20 mics or even higher. But 1 to 4 usually gets the job done for sepsis. 4 micrograms is something that we start patients on in the emergency department. You're not going to be held to really what kind of dose you're going to hold the patient to initially, because that's protocol driven, but the protocols must now state Levofed is your drug of choice. So if anything else, norepinephrine, in other words, Levofed, first drug of choice. We also found from these studies that dopamine is associated with the increased risk of arrhythmias and increased mortality compared with norepinephrine in the setting of sepsis when the patient has a cardiac arrhythmia. We are less likely with dopamine to create an arrhythmia, but if the patient has a pre-existing condition that involves an arrhythmia, such as atrial fibrillation or any kind of heart block, dopamine is not supposed to be used. So this is why Levofed has taken over first place. Dopamine is associated with increased risk of arrhythmia and therefore can slide into ventricular fibrillation or ventricular tachycardia, and then obviously death. So let's talk about the criteria for a second. Now, these 6 things you're going to have to kind of sort of commit to memory. Your protocols, hopefully to whatever fire department or EMS agency that you will ultimately belong to, will state these 6. And so without reading them to you, most people would agree that you need a person with either a systolic pressure of less than 90, and that as a result creates some altered mental status. So those 2 are kind of work together a bit. So if you have a systolic of less than 90 and altered mental status, then really it's just a matter of picking up what else is going on with the patient. And what you're going to see here is systolic pressure, heart rate, and you would think, well, tachycardia greater than 100. Well, the heart rate is actually 90. That's what's defined by the NIH. And your temperatures, you should know both from a Fahrenheit standpoint as well as from a centigrade standpoint. So make your calculations appropriate to the situation here, and you'll find out that it's about 36 degrees centigrade or less would be a hypothermic patient, or 38.3 degrees centigrade and higher is 101 degrees Fahrenheit. Respiratory rate will be greater than 20 per minute. And for some of you agencies, and this is going to become more popular now, but they're going to ask the question on the registry exam, is serum lactate levels. Lactate is the same word for lactic acid. It's kind of a shorthand form. You call something citric acid, it's citrate. Same thing with lactic acid, it's lactate. And you go on and on and on with pretty much any acid that's out there. So you'll see lactate, lactic acid used interchangeably. It's the same thing. So more times than that, you want to say, all right, patient's got an altered mental status and they got some abnormal vital signs here. What's the first thing we're going to check? And the answer is, of course, blood glucose, especially in diabetic patients. But definitely if the glucose is less than 70 in an altered patient, you want to at least give them the benefit of some glucose here as well. EtCO2, end-tidal CO2 has become a more prevalent diagnostic tool to help us out in systems that do not have lactic acid monitors, which is about 99% of the country. The advent of lactic acid machines in the field, which are as easy to use as a glucometer, has not quite hit mass production yet, but it will be. So at some point, whether you're in the emergency department or rotations, whether you're in the field and you do have a lactate, greater than 4 is considered enough lactic acid being produced as a result of hypoperfusion that your patient can now be considered septic. All right, so capnography, let's talk about that for a second. Capnography is a reliable monitoring device. It's not perfect, but it's reliable. When lactic acid is rising in the bloodstream, The body's natural response to that acid is to blow off the acid, and we do that by picking up the respiratory rate. So we start blowing off CO2. Which is the converted product of acid, carbon dioxide, to help maintain that pH between 7.35 and 7.45 in the body. Well, as more lactic acid is produced, pH goes down to 7.2, 7.15. Subsequently, the first line of defense of the body is to normalize that, because everything works much better between 7.35 and 7.45. So we start to blow off CO2, and we do that by picking up our respiratory rate, 24, 26, 28, 30, 30, 40 a minute. We're really huffing and puffing to try and balance that out. As a result of that, you blow off way too much CO2. The end tidal CO2 now picks that up. And whenever you get an EtCO2 of less than 25, this correlates to a lactic acid level of greater than 4. Now, this is kind of opposite of what you would think. You would think that, boy, the more lactic acid that I produce, I'm going to start blowing off CO2. And so if there's a real high lactic acid in the body, I should have a real high CO2. It's not CO2 that's elevated. It's the lactic acid. We're blowing off CO2 to counterbalance. The CO2 has nothing to do with the lactic acid at this point. So the EtCO2 becomes reliable, but inversely proportional to what you're doing here. So the higher lactic acid, the lower your CO2, because you're trying to blow it off to prevent the pH from going any lower. And you may have to look at that concept a couple of times to get a good handle on it, but it's an important concept, because a rising CO2 either tells me your patient's going into respiratory failure or you're dealing with another issue, such as diabetic ketoacidosis. So now, what can screw this up? COPD? Well, geez, how many people have seen COPD in nursing home patients? Pretty much a lot of them. Asthma, many of them. Pneumonia, quite a few of them. Congestive heart failure, oh yeah. So whenever you got any kind of primary lung process in the presence of sepsis, the EtCO2 may not be as reliable as it would be if it's an intra-abdominal infection or a sepsis caused by cellulitis or abscesses or any number of the other causes for infections in the body. So let's talk about release of chemicals. The chemicals that are released in the body as a result of sepsis are called cytokinins. Now, you imagine this E. coli looking bacteria, or this Klebsiella, or the Staphylococcus or Streptococcus, or the pneumococcus, or any one of a number of bacteria. It gets released and the body is trying to handle it, but it can't. So the bacteria proliferate. They grow in numbers. They grow in size. Each one of these bacteria release a chemical into the body. Once that chemical hits the body responds to neutralize that chemical. However, cells are being damaged at the same time by those chemicals. What's released is cytokinins. It's those chemicals that are doing the damage to the body. The body's destroying itself, unfortunately, as a result of the bacteria. Inflammatory response are the release of chemicals, and the release of chemicals and that inflammatory response we abbreviated as cytokinins. So cytokinin hits the vasculature, hits the arteries, hits the veins, and what does it do right away? It interferes with the body's natural response and causes vasodilation. That's why it's called distributive shock. Distributive shock is an inadequate tissue perfusion caused by the release of cytokinins from the bacteria and from cellular damage, which interferes with the smooth muscle of the arteries. It's not skeletal muscle. It's not voluntary muscle. Smooth muscle surrounds any and all arteries all the way down to arterioles, which is the smallest of the arteries. Once they become capillaries, they lose their muscle layer. But we can still regulate vasoconstriction, vasodilation at the arteriolar level. However, cytokinins interfere with the response, and what happens? Everything just vasodilates. When that happens, the usual 6 liters of blood that we have in our bloodstream, well, if we vasodilate, now all of a sudden we got a requirement for 8 liters. And proportional to the patient's weight and size, of course. So if I'm normal at 6 liters with a 120/80 blood pressure with a pulse 80, respiratory rate at 12, now all of a sudden I'm septic and I vasodilate. Well, what's going to happen in response? Well, heart's going to pump a little faster. It's going to pump a little harder initially. So now my pulse rate's going to go up. Initially, the blood pressure will go up, but ultimately, as I fully vasodilate, I can't push enough stroke volume around the body because the tank isn't full. I'm not bleeding from anywhere. The fluid isn't leaking out of me onto the floor. It's still in there as 6 liters, but now it's an 8-liter capacity body, whereas before it was a 6 liter. So now that I've lost about 25% of my capacity to pump blood, I start going into shock. This is why it's a redistribution, a shunting and a vasodilation is why everything redistributes. So now you're going to get a shutdown in the periphery. And it's going to try like heck to vasoconstrict, but it can no longer do that. So initially, your extremities feel warm. Your capillary refill is fine. But then as it progresses, as the body starts to say, hey, look, I don't have enough fluid to push this around at all, I can't put out the stroke volume. Now the blood pressure drops. Without that adequate perfusion, without that adequate blood pressure, I can't perfuse the tissue. Therefore, I lose the blood's ability to go into the tissue and oxygenate and bring out lactic acid and bring out CO2 and bring out all the other happy stuff. By the way, people know the results of lactic acid. If you're any kind of athlete or if you've done any kind of exercise and you develop muscle cramps, that's lactic acid. A buildup of lactic acid in your muscle causes cramping. Imagine what an entire body full of lactic acid does. It can really cause patients quite a bit of discomfort, but because of the low blood pressure, they have altered mental status, they can't tell you that they're cramping up. And then subsequently the muscles relax because they don't have enough oxygen and it starts to die off. So think about inadequate tissue perfusion is the definition of shock, and it's the result of the body's loss of ability to compensate for the decreased volume as a result of the vasodilation interfered with by the cytokinins. So said another way, cytokinins cause vasodilation, makes for a body's requirement for an increased fluid, but that fluid isn't there. Subsequently, low blood pressure, hypoperfusion, cellular death, release of more inflammatory cytokinins. And as you can see, it's a vicious cycle. So who are the people that get these kind of things, and what criteria can we apply to these patients? Well, the first things first, we got to figure out who's at risk and what kind of interventions are we going to require based on those risks. Generally, although, and this is very important, sepsis and septic shock can occur at any age. Okay. So generally, however, the patients are greater than 18 years of age. You'll want to ask how long you had the fever, how severe is the fever? In other words, what kind of effect has it had on your body? Generalized muscle aches, fatigue, malaise, difficulty moving out of bed? Are you shaking, chills? Severity of the fever. is there altered mental status? You should be able to tell that within about 5 seconds. Their past medical history, I can tell you that patients with congestive heart failure, COPD, asthma, or any other type of lung disease, even the rarer forms like cystic fibrosis, cancer patients and such, all these patients are at high risk. And we list some immunocompromised patients down at the bottom of the slide there. In other words, anybody who's got an altered immune response. So you can imagine leukemia patients, probably any kind of cancer patient. And the big one, of course, is diabetes. You'll find a majority of your septic patients are in type 2 diabetes. The type 1 diabetics usually take pretty good care of themselves, but every once in a while you run into a patient who slips into DKA because they've slipped into sepsis, and now we got ourselves a hell of a mess, to be honest with you. So past medical history is going to be extremely important, especially recognizing patients who are at risk for these different causes. And we're going to go over those causes now. So pneumonia, 5th leading cause of death in the United States. Sepsis, 3rd leading cause of death in the United States. So you can see the interplay there. Urinary tract infections. How many people have pulled elderly patients out of a nursing home that have ultimately had cloudy urine or catheters that look like they're all clogged up with all kinds of debris? Urinary tract infections portend into kidney infections, and pyelonephritis can be very, very difficult to treat. Once those kidney infections take off on you, you can start losing patients. When I was in residency back in the 80s, I actually lost a 21-year-old woman who came into me septic, who was 8 months pregnant, lost her, lost the baby, lost everybody. These are, once they come into you looking like that, altered, low pressure, temperature 103, 104, your mortality starts hitting 80% very easily. Now, cellulitis, it's not so much the infection that's on the arm or on the leg. The diabetic ulcers, the pressure ulcers and such like that, those can make a patient septic. You get what they call Fournier's gangrene, which is an infection in the pelvis that then finally leaks out into the skin. By this time, you're developing gangrene and such. But diabetic ulcers, pressure ulcers, are probably the most common source of infection that results in sepsis. Abdominal infections. Now, this is going to be real important from a standpoint that when you arrive on the scene and you've got a patient in their home perhaps has a history of diverticulitis or recent surgery, especially bowel surgery, gallbladder, appendix, any surgery at all in the abdomen where the peritoneum has to be open to access the organs, intra-abdominal infections are a huge cause, because sometime around the 7th to 10th day post-operatively, the patients are at highest risk for developing abscesses. And these abscesses are some of the most wicked infections on earth. It's not that little pimple-looking kind of boil that you got on your arm or anything like that. These abscesses can sometimes be grapefruit size. I mean, 5, 6, 7 centimeters. They're pretty big. And subsequently, the leaking from the abscess of these bacteria and the cytokinins as a result of that can be a big blast to the body. I mean, it just really hits. So you got this abscess and it's walled off real nicely by the body. And then it gets bigger and bigger because the bacteria are multiplying and multiplying. So around day 7, you know what, I'm just not bouncing back. Day 8, I feel a little warm. I don't feel very good from a nauseous standpoint, so I'm going to drink a little fluids, maybe an episode of vomiting. And then around day 9, day 10, all of a sudden you're pale, diaphoretic, not much of a blood pressure, and you're really in trouble. So you got to start thinking about these things around day 7 post-operatively. And subsequently, this is what's going to require aggressive management all the way around, from EMS all the way through to surgery. And then, of course, anybody with susceptible to meningitis, so it's going to be any immunocompromised person or any 18 to 25-year-old who resides in a military base or a college dormitory where meningitis can occur. Now we're seeing less and less meningitis these days with the meningococcemia vaccine and the HIB, the Haemophilus influenza type B, which are two of the most common causes of meningitis in the age 12 to 55 range. And you don't need to know that age range, but just know that anybody who comes back from a military encampment where there's close quarters, or students at a college campus, close quarters. Before the coronavirus thing, it was common to have close quarters because that's just what we do as a society. Coronavirus may change all that, but you still have to suspect meningitis. So those are the big five. All right, here's our treatment. Like I said, this is going to be fairly straightforward. The first thing you do, whether you're doing my graduate interview with me, or when you get on the scene, or whether you're in the emergency department doing rotations, you're going to apply oxygen to these patients. Well, pulse oximetry is 95%. Great. The pulse oximetry at 95% is measuring the blood that actually makes it to the finger. That doesn't tell me anything about the blood that's not making it to any other tissues. So we're going to supersaturate. We're going to go for 100% here. They're a COPD. All right, I'll deal with it. Your EMS, get them on 100% oxygen. You may want to tone them down to 4 or 5 liters per nasal cannula. That's fine, but most people will get a non-rebreather at 10 liters, 15 liters, whatever you feel comfortable with, to help improve. If they're a pneumonia, in other words, you can listen to them, they're really having shortness of breath and you can't hear all the noise, then go ahead and start them on an albuterol aerosol with Atrovent. The albuterol is going to bronchodilate, Atrovent is going to dry them up. And we need that decreased mucus production to help us. You're going to get your standard vital signs: blood pressure, pulse, respiratory rate, temperature. But I want to make sure that you got your temperature, EtCO2, and pulse oximetry. You need a 12 lead. You know, the minimum 3 or 4 leads to monitor, but you're going to need a 12 lead to see if you piled a heart attack on top of this whole thing. Sepsis, hypoperfusion, heart gets hypoperfused. What does the heart do? It gets pretty upset, and you can have an MI at the same time. And next thing you know, you've got yourself a 5-alarm call going on here right now because your patient's getting ready to meet our maker. And it's going to be up to you as the only person standing between them and the grave to react to the situation promptly. You're going to check a blood glucose. Let's make sure their altered mental status is not due to a blood sugar of less than 70. If it is less than 70, take your D10, 100 mLs, run it in. We'll be fine from that standpoint. The altered mental status may correct. If it does, we win. If it doesn't, at least we've taken glucose off the table. Now you're going to start your IV at 0.9 normal saline. You're going to do so at 20 milliliters to 30 milliliters per kilogram. Can't emphasize this one hard enough. It is on the exam, the National Registry. So it's going to be normal saline and lactate. It depends on what your particular system is. It doesn't really matter to us. We prefer the normal saline because lactated ringers has a pH of about 6.5. And we'd rather not add acid to an already acid situation, but within a short period of time, once you restore volume, you'll be in a better shape. And so the lactate may take a little bit longer, but not appreciably longer. So we don't distinguish between normal saline and lactated ringers. If your protocol says LR, go for it. If your protocol says NS, go for it. They won't distinguish between the two on a national registry. They're not going to pimp you like that. They're not going to say choice A, normal saline, choice B, lactated ringers, choice C, D5W, choice D, nothing. The only thing that's really wrong here is D5W. That we can't handle. There's too much leakage, too much permeability going on, and the water will just go right into the third spaces. Doesn't stay in the intravascular system longer than 15 minutes, and then you're just not doing anything for the patient. NS or LR. Now, you give a bolus. You give your 500 cc's or your 250, whatever it is. But we would prefer that your bolus be based on 20 to 30 milliliters per kilogram. So what do you do with your 100 kilogram, 220 pound patient, just to make it easy? 2 liters. And that's going to be a bolus, which means it's going to go 1 liter in over about as fast as you can get it in. If their pressure is less than 90, especially, you want to give them 20. If their pressure is okay, but you see that they're in sepsis, then go ahead and give the 2 liters over 1 hour. That's a liter every 30 minutes. Open up the first one, open up the second one right after the first one. You'll find that when you give 20 to 30 milliliters per kilogram bolus, that we're restoring the distributive shock part of this whole pathophysiological deleterious event of cascading that's going on. We've already talked about the cytokinins interfering with the body's ability to vasoconstrict. Now you've got a completely vasodilated system. And a normal person who's 6 liters in their vasculature vasodilates, now they have a requirement for 2 more liters. Those 2 liters is what's calculated from the 20 to 30 milliliters per kilogram. So if you got a lightweight sitting there like a 70 kilogram, a 60 kilogram person, make your calculations accordingly, but get those fluids in as soon as you can. Most of the sepsises out there can restore their blood pressure with just a 20 to 30 milliliter per kilogram bolus of fluids. It's amazing how much can be corrected just with that. But now you may ask, well, if you look down a little bit lower where it says Levophed, why would we use Levophed? First of all, patient may be in congestive heart failure because they've had an MI, and they had the MI because they're septic. All right, they're probably not going to do very well with large fluid boluses. You want to slap CPAP on them and give them at least a 500 cc fluid bolus. I'm fine with that. Your back is really to the wall in this patient. They're really trying to die on you. So you slap the CPAP on, you give a 500 cc fluid bolus, and you find out that, oh my gosh, I got a 30-minute run to the hospital. You may want to start your Levophed then. You may want to start your Levophed in any time that you don't feel that a fluid bolus is going to be beneficial to this patient or will actually be deleterious. Anterior wall MIs is a big one. Don't fluid overload these people. People that are already in flash pulmonary edema. Man, I can't give them any more fluids. So I'm going to start them in maybe a 250 bolus after I put some CPAP on them and give them the benefit of some fluids. But I got to start the Levophed. And so you'll start it between 1 and 4 initially, 1 and 10 initially, whatever your protocol calls for. But we generally in the emergency department start our Levophed at 4 micrograms per minute. And we start it whenever we feel that we have to start it. If I've given 2 liter bolus and I still can't get the pressure up, I move the Levophed. So think about that for a second. You're en route to the hospital. Your runtime may only be 20 or 30 minutes. You've just barely enough time to get the fluid boluses in. Sometimes that's all that you need. Most of the time, that's all that you need. But for that time where you're more than 30 minutes away, for that time that the patient's in CHF and has an MI going on, or for those times where you don't feel that, this patient's already with ascites, anasarca, they got pedal edema all over their body, they're 4+, you poke them, they look like, dots all over them because the edema is just so great. All right, we may want to move to Levophed right away. And that would be the time that you would do that. Patients with heart histories and such like that don't do well with dopamine. Causes increased arrhythmias and can increase the risk of mortality by quite a bit. If you're stuck or if that's all you got because your system says dopamine's better, well, carefully direct the medical director, who's probably not a board certified ER doc if they're still using dopamine. But if they are, carefully go back and tell them, hey, we heard that Levofed is kind of first in line. Check out your ASEP literature, check out the National Institute of Health, check out the CDC, check out any reliable source that are out there, doc, and let's see if we can't move to Levofed. I will admit this, dopamine is less expensive than Levofed, but Levofed is not $1,000. It's not TPA, okay? Levofed may be 50, 60 bucks a bag. Dopamine's about $35 a bag. That, as far as I can see, that's not much of a difference to justify the risk of dopamine. So Levofed is your drug of choice for cardiogenic shock and now distributive, in other words, septic shock. Okay, so I beat that one to death. Here's our case study. And this is going to look very suspiciously like the case that you're going to get in your graduate interview. You arrive on the scene of a 55-year-old female with generalized malaise, fatigue, and weakness. She has a temperature of 101.5 this morning. Had a problem getting out of bed, and when she did, she almost had a syncopal episode. About 1 week ago, she had surgery to remove her gallbladder. Patient complains of quite a bit of nausea, one episode of vomiting, very intense abdominal pain. She hasn't eaten anything in the past 48 hours and nothing more than some sips of water. So already that should be telling you that there's about 5 things going on here right now that you're going to need to correct very easily. Now, her past medical history is significant for type 2 diabetes, hypertension, coronary artery disease. Vital signs are as stated there. She is running a temperature of 101.5. She is hypotensive. She's answering questions, but she's lethargic. Lungs are clear, no rales, rhonchi, wheezing, full and equal breath sound. Abdomen, no bowel sounds, rigid, extremely tender. No fluid wave or unusual distension. Here we go. There's your scenario questions. What kind of shock is this classified as? We already know from our previous conversation. You should have chose distributive. Distributive shock, again, chemicals are released, the cytokinins, then interfere with the body's compensatory mechanism to vasoconstrict to compensate for the decreased volume that's occurred as a result of the sepsis. So they're losing water, they're losing their ability to maintain water. They're going to have decreased urine output and such. That may be a question you may or may not want to ask, but distributive. In other words, we're not able to move the fluid around as easily, and so the body starts its own process of shunting to keep perfusion to the intestines, kidneys, heart, and brain. That's why you're going to get peripheral shutdown, distributive shock. Okay, which of the following statements is true regarding sepsis and septic shock? All right, the answer to this one is pretty straightforward. We did emphasize it during the lecture. Sepsis can occur without regards to age. You can have children or infants that are septic. Most of the time in infants, it has to do with pneumonia, urinary tract infections, or meningitis. Watch for the meningitis. Okay. These patients are still going to require fluids, and that's going to be your job. If the patient is really lethargic and it's a no kidding 5-alarm emergency and the kid's not doing well, you'll be probably intubating the patient, but you're going to be dropping an IO on these kids, and there's your 20 to 30 milliliters per kilogram. Now, for the kids, 20 milliliters per kilogram over 1 hour comes up to 60 milliliters per kilogram in 1 hour, because you're going to give 20 milliliters per kilo as the first bolus over 15 to 20 minutes. And then you may give a second bolus, then you may give a third bolus. Once you hit that 60 milliliters per kilogram total, 3 20 milliliter per kilogram boluses, That's about all you're going to get out of an infant or a child, unless it's due to anaphylaxis or some other form of distributive shock not related to sepsis. Okay, and that's where the red patch comes in. That's where the paramedic patch comes in. Is that you're going to make that decision. Geez, if this is anaphylaxis, maybe I can give a little bit more fluid. That's fine, but we're talking about sepsis for right now. So 3 20 milliliter per kilogram boluses within the first hour equals 60 per kilo. Don't go over that. And don't put it in any faster than that. 20 milliliters per kilogram over 15 to 20 minutes is adequate as a first bolus. Repeat as necessary, up to 3 boluses. But know this, no matter what you're talking about with sepsis and who it's likely to occur in, sepsis can occur in any age. Sepsis most likely occurs in patients 55 and older. Sepsis and septic shock occurs in pediatric patients as well as adult patients. And sepsis, like I said, can be a 16% mortality if you do everything right and caught it early. It could be a 30% mortality once they slip into altered mental status. And then, of course, once they have the fever, altered mental status, and all the abnormal vital signs, including the less than 90 systolic pressure, their mortality hits 80%. So sepsis is the 3rd leading cause of death in the United States. All right, recommended fluid resuscitation and management of septic shock. Right back again, 20 to 30 milliliters per kilogram. The other answers, this third one could be right if your patient weighs 100 kilograms. Then it's going to get 2 liters over an hour, and you'll be in good shape there. But we do it on weight-based here because you're going to get lightweights that are 50, 60, 70 kilograms. And of course, you could very well get a bit of a heavyweight who's 250 plus, where they would require more fluids. So 20 to 30 milliliters per kilogram will be your standard, and this will be the answer whenever it appears. Okay, now read this question carefully. I'm asking for the best way of the choices here, not the best way in how to assess sepsis. The best way of the choices present to assess hypoperfusion and septic shock. All right, you should have picked choice C. Remember, this was the paradoxical thing that we talked about. You see a patient that has lactic acid built up. So what we try to do is blow off the acid that we can. Carbon dioxide is the only acid that we can do that to. So we blow off carbon dioxide to balance the rise in the lactic acid. Here's the CO2. As lactic goes up, we're going to try and bring this down to keep that pH right in the 7.35 to 7.45. As a result of blowing off all the CO2, your end tidal CO2 is probably going to be less than 25. And here's the key. A study has come out that tells us reliably that a end tidal CO2 of 25 or less correlates to a lactic acid of 4 or more. And a lactic acid of 4 or more is the criteria that establishes sepsis. The best way to do this, lactic acid, for 2 reasons. Number one, it's a direct measurement of the lactic acid. And remember, when we do end tidal CO2, we're kind of doing an indirect of the lactic acid. In other words, we're blowing off CO2 to compensate, but we can't measure the lactic acid through the end tidal CO2. So it correlates at less than 25 equals greater than 4. But it may be skewed in COPD or asthma, diabetic ketoacidosis, cystic fibrosis, pneumonia, congestive heart failure. anything that has to do with the lungs or produces acid for another reason in the body. So end-tidal CO2, your EMS agency, your fire department may say, well, you got end-tidal CO2, that's good enough. Yeah, okay, good enough, but it's not the best way. Best way is to actually take a glucometer looking type machine called a lactic acid measuring machine and do the finger prick and get the glucose, and then with the second strip you get the lactic acid, or better yet get an iStat, does it all at the same time. And that's the direction that paramedicine is heading. We want to give you guys more tools out there to decide exactly what's going on by direct measurement, not so much by indirect measurement, which is what end-tidal CO2 does. But for now, close enough. It puts you in the ballpark. Okay. Now, what's the most reliable lab indicator of hypoperfusion? Well, we just talked about this ad nauseum. Numero uno is lactic acid. That's the result of inadequate tissue perfusion. Anaerobic metabolism in the muscles in the periphery produces lactic acid. Okay, again, this is another best answer. Okay, it's not the complete answer. It's not the sine qua non. It's not the pinnacle. It's not the top dog or the big banana or anything like that. I want you to look at these four choices, and decide which one is the best or the most complete that incorporates all the elements that we talked about earlier. I'll give you a minute to think about that one. All right, so what you should be looking at here is cytokinins released as a result of inflammation, infection, such causes damage. Damaged cells and bacteria themselves both release cytokinins, which cause inflammation, and it causes vasodilation and therefore hypotension. Your correct answer here is the last one. Now, why is number one wrong? The inflammation cytokinins do not cause vasoconstriction. That's the problem. If we could vasoconstrict, we wouldn't have low blood pressure. We'd be in good shape. So, and you can't over vasoconstrict if you're septic. That's just diametrically opposed. Cytokinins interfere with vasoconstriction, cause vasodilation, and takes that nice 6 liters that we have in our bodies and changes it into a requirement for 8 liters, but we only got 6 in there. So we've lost a lot of volume. Not that it's leaked out, but we have to replace those 2 liters to fill the tank back up. Now, the second answer is not far off. That's a late finding when you start the third space fluid. In other words, capillaries really start to leak, and the damage to the capillaries becomes so great that you can have a little bit of bleeding as well. That's called petechiae. You look like little red little blotches all over your skin. You see this in meningitis, especially in the legs. That's where meningococcemia in young adults goes to. Causes leaking capillaries, causes damages to the capillaries from the meningococcal bacteria. And as a result of that leak, blood leaks out and you get petechiae. That's a late finding. The actual hypoperfusion is the result of the last answer there. Hypoperfusion is a result of vasodilation. Again, the tank needs to be filled up. In the third answer here, damage to the myocardium, decreased contractility. Again, that's a very, very late finding. That's usually the end game, where your heart finally is attacked directly with the cytokinins, and you lose contractility. And as a result of that contractility, you drop your pressure so low that you can't sustain life. But again, the pathophysiology, in other words, the mechanism, is inflammation causing vasodilation, which results in hypotension. Now, I think this is the last one, and then we're going to wrap this up. Now, I want you to take a look at these elements. And we talked about 6 elements a little bit earlier. Again, it's one of these answers here. The complete answer may not be the longest answer. You're looking for the complete answer. That's why I told you to memorize the 6 elements. See if you can't pick out which one it is. All right. So let's give it a whirl here. Correct answer here is going to be D. So let's take a look at the reason. Altered mental status is a must. You're going to really need some sort of altered mental status, whether it's lethargy or a little slow speaking or whatever it is. This is a requirement, plus an ETO2 of less than 25. Contrast that with answer C, where I put the ETCO2 is greater than 32. If it's greater than 32, you've got something complicating the sepsis that's confusing the picture. More likely than not, diabetic ketoacidosis. But even poisonings can cause this issue as well. So ETCO2, again, inverse proportional to the lactic acid. As lactic acid goes up, the CO2, which is also in the bloodstream to help maintain pH as a compensatory mechanism, will go down, but the only way the CO2 can go down is if you blow it off. So your respiratory rate's going to be greater than 20, probably 26 to 30, somewhere in there, but your respiratory rate's going to be greater than 20 in an effort to blow off the CO2 to compensate for the rising lactic acid. Once your pH gets below 7.2, 7.1, you're in a heap of trouble. Usually below 6.9 is incompatible with life. Doesn't take much to get there. Okay. Body does a pretty good job with compensation, so you're not going to get an infection, die within the hour, but you will die within 6 to 12 hours if that sepsis is allowed to run unchecked. We then look at the lactic acid. All right, if you have a way to measure the lactic acid, then 4 or greater establishes the diagnosis. Respiratory rate, we talked about, heart rate greater than 90. So those are your 6 criteria and your elements for sepsis and septic shock. Now, what did I exclude here? I excluded the requirement for the blood pressure. Generally, a systolic pressure of less than 90 establishes shock, but that wasn't one of the choices here. The best answer here was the last one. But also recall that systolic pressure of less than 90 is also one of the elements. Now, here's the key. You need altered mental status plus 2 other criteria. You don't need all 6 of them. So if I've got a fever of 101.5 and I have a systolic pressure less than 90, but I'm alert and awake, I could very well still be septic. If I have a respiratory rate of 30 and I'm alert and awake and a good systolic pressure of 150, but I've got an ETCO2 of 25 or 20, then I've probably got sepsis. All you need is 2 of those criteria plus the altered mental status or the low blood pressure. The way you're going to see it on the National Registry is going to be, here's your scenario, here's the question based on a scenario. It's not going to be a single answer, single statement thing because sepsis is not that easy. But we will paint you a scenario that says, by the way, blood pressure is 86/50 and the heart rate's 120 and the temperature's 101.3. They just had abdominal surgery. What's your first line of treatment? Fluids, 20 to 30 per kilo. Okay. All right, that's the end of the slideshow. That's the end of our discussion for this evening. Does anybody have any questions?
Folks, you can unmute your microphones if you'd like to ask a question, but let's start with Michael. You got any questions or comments for Dr.?
No, I don't have anything, but we could barely hear you, Jane. Barely.
Okay, I got that he didn't have any questions, I think. So
Yes, he did.
moving on to Shaughnessy, what about you?
No, I really can't think of any. The only thing I was gonna comment on was that there's a lot of services that are talking, well, more city services that are talking about starting antibiotics on the truck. What are your thoughts about that in this?
Oh, no, that's an absolute requirement. And as we start teaching sepsis at the national level, and as we teach it at the state level, we're going to start getting lactic acid monitors out there, or at least getting everybody acquainted with the sepsis protocols. Now, here's the way that I see it. Here's the way I got my guys in Sherman getting ready to do this. If your patient is septic and you feel reasonably that it's a result of pneumonia, then you will carry Rocephin. And a Rocephin 1 gram IV piggyback will be given. Now, you need to do two things before that happens. First, you need to draw off 2 sets of blood cultures. Second, you need to draw off the lactic acid. Even if you don't run your lactic acid as a lactic acid machine out there, but you got an EtCO2 less than 25, or you got every reason to believe it's sepsis, then you start the Rocephin. What the Rocephin is going to do is it's going to sterilize the bloodstream and stop the production of cytokinins from the damaged cells because you're destroying the bacteria in the blood. Now, does that cure them? Absolutely not, but it's a great start. If your patient sepsis is not related to pneumonia, then we switch gears. If it's a cellulitis, intra-abdominal infection, or meningitis, then we give Zosyn 4.5 grams IV piggyback. Now that is a very powerful penicillin medication. What do you do if your patient's allergic to penicillin? Well, then you start a medication called ertapenem or meropenem, and these are all fancy names for 4th generation penicillin-like medications that don't have the penicillin ring. Therefore, they won't be allergic to this medicine. It's perfectly acceptable. So really, we're talking about carrying 2 antibiotics. Rocephin, it's pneumonia. Meropenem, if it's anything else but pneumonia. The reason being is we don't have allergy information a lot of times on patients, and so I wouldn't feel comfortable starting penicillin agent on a patient that I don't know anything about. There's still quite a bit of penicillin allergy out there. But let's say you've got a good patient and they say, no, I'm not allergic to anything, or I'm allergic to Bactrim. Then you start your Zosyn, for instance, that case scenario I gave you earlier, where the patient had an intra-abdominal infection. Well, Zosyn is the greatest thing since sliced bread for the intra-abdominal infection. So the long answer to your very short question is we favor antibiotics being delivered in the field, and we are moving towards that end as a nation to make that happen. Right now, it just quite hasn't caught on except for the most progressive, if you will, of the systems that are out there, and we're doing it up here in Sherman as we speak. Does that answer your question?
Yes, great, thank you.
Very good. Who else do we got, Jane?
How about you, Chris?
I think I thought it was really informative. I think the antibiotic question was a good question. I would have, maybe asked myself. But I thought it was good. I feel like I learned a lot from it. I don't think I
Great.
had anything.
Know the slides, you'll know the questions for the exam. These slides are very suspiciously similar to the questions that are going to appear in the National Registry.
All right, good to know. Thank you.
How about you, Rebecca?
Yes, ma'am. I heard him say Rocephin, but I could not hear what the second antibiotic was. My audio was cutting in and out.
That's
Was it
okay.
Zosyn?
Zosyn, Z-O-S-Y-N.
Perfect. Thank you.
No problem.
And I guess last is you, Taylor.
So I am going to be that guy that asks a question. And it's actually going to be 2 questions. Keep it as quick as possible. So I'm going to work it. I work in a different setting than anybody else is going to be in this forum, as well as I am a Border Patrol medic in one of the most rural areas of America, and we encounter sepsis quite a bit. I have 2 paramedics, and the county EMS has 0. My guys do not carry level fed. The closest to any pressor capabilities we have is epi. And so, long story short, my flight time to get a helicopter to me, best case scenario, an hour. Best case scenario, flight time to Tucson or El Paso, hour to hour and 15. So, 2-part question. We had a pediatric that died on us. Autopsy showed 5 days sepsis. Do pediatrics, if we would have encountered them at day 1, present any differently than an adult? And question number 2, what are your recommendations for long-term management of septic patients when we do not have strong pressure capabilities such as level fed?
As far as children are concerned, they compensate much better than adults. So you may not see them crash as fast as an adult. As a matter of fact, they're kind of cliffhangers, where adults kind of linger down and they kind of fade off. Kids come along and then all of a sudden they drop off the cliff. So they're compensating, and all of a sudden they just crash on you. So early signs are going to be difficult to tell, except the kids tend to get tachycardic pretty quick. And when they go distributive, in other words, when they do the initial vasodilation, their extremities actually feel very warm, but it blanches very easily. Now, you may say, well, geez, if I'm in the Texas sun, I can get the same thing. Yeah, you're exactly right. There's no easy way to tell that. Second, to your second question now is, what do you do when you're only carrying epi? Well, it's not the desired drug, but it's adequate. And subsequently, if you took a 1 to 10,000 and threw it into an IV bag and gave the kid bolus over 1 hour, you'll find the epinephrine will, in that particular case, sustain their pressure, at least for the time being. Now, remember, epinephrine is a catecholamine. It only lasts about 10 to 15 minutes in the bloodstream, but it should be long enough to cause a vasoconstriction that will last at least 30 minutes. You may end up repeating it, but when given in combination with fluids, in other words, you're not standing there pushing it IV push, but if you throw it up into the bag pretty early and run it in as a continuous infusion over 1 hour, you'll find that you can probably sustain the children for the short term. I'll assume that since you don't carry Levofed and anything else like that, an antibiotic is out as well. Kids, more than any other population out there, respond the best to Rocephin. Rocephin kills everything that a kid can get. It's very, very rare that children will have any intra-abdominal infections, mostly pneumonias, urinary tract infections, or meningitises, and Rocephin blasts all of those right out of the water. But if you're not carrying antibiotics, you got to do the best you can with what you got.
Yeah, it's just the nature of the environment that we work
Yep.
in. It's different than anything else that a lot of the people that are going through this program will probably ever experience. I mean, I'm getting flown in on the top of mountains and hiking people down. It's taking me 2 hours to get them down. So it's just different.
Yeah. It is, but it's necessary. Wilderness medicine, mountain medicine, even tropical areas that we run into in the world. Being a Air Force squadron deputy commander, you can end up in any austere environment in the world, including Antarctica, or getting on top of those bigger mountains where you're dealing with snow. You might as well be in Antarctica. So the need there is, yeah, you got to pack light because 1 pound down here feels like 10 pounds up there. But at the same time, yeah, you got some tough decisions to make what to put into your backpack to decide what's going to benefit the most people going up there. And I appreciate the job that you're doing. All right. Well, if nobody else has any questions, I hope you did well in the questions that I put at the end of the lecture. Again, the case scenario will be something that you'll see in your graduate interview. The slides and all the information on the slides that we emphasized will appear or likely